Hello, everyone. I'm Jen Childress, Director of Programs at the National Forum for Heart Disease and Stroke Prevention. Welcome to today's issue briefing, Dialysis Payment Changes in Cardiovascular Health, Navigating Risks and Supporting Innovation. This event is brought to you through the National Forum's Value and Access Collaborative and made possible by support from Ardelyx, BMS Pfizer Alliance, Novartis, and Regeneron. National Forum briefings aim to present multiple perspectives without bias on timely, controversial policy issues. We are pleased to have Dr. Gary Puckrin as moderator for this event today. Dr. Puckrin is the founding president and chief executive officer of the National Minority Quality Forum, NMQF, a nonprofit healthcare research, education, and advocacy organization headquartered in Washington, D.C. He earned his doctorate from Brown University. Now over to you, Dr. Puckrin.
Thank you so much, Jan, and good afternoon to everyone. Before we get started, I wanted to do a little bit of an audience poll. And the question is, how would you rate your understanding of the recent CMS payment policy changes and their impact on innovation in cancer care? Great. So what I'd like to do is start off by introducing our distinguished panel this afternoon. First, I'd like to introduce Dr. Shira Lekha Tumalapalli. Oh, there's our results coming up. Thank you so much. So at least that some people have little understanding, some people have a basic, but hopefully by the time we get through this afternoon, everyone will at least have a moderate to strong understanding of the poll. So thank you. Back to the introductions. Lauren Randall Buckley will be joining us. Jeffrey Paramuter will be joining us, and Dr. Paul Underwood as well. And I think you're going to really enjoy this panel today. What I'd like to do is first say a little bit about the National Minority Quality Forum and its partnership with the Association of Black Cardiologists on cardiorenal disease. We are coming together because obviously the disparities in renal disease is really important in the African American and Hispanic community, and generally speaking, in the United States more generally, it's the ninth cause of death in the country. And we're taking a deeper look at what's going on as it relates to cardiometabolic renal diseases in minority community. I'd like to tell you a little bit about how the National Minority Quality Forum on its side is approaching this issue. I'm going to ask some slides to come up. The National Minority Quality Forum, we just launched a series in health affairs introducing what we call the Physical Laws Framework. Next slide. It is a 15-blog series that is really focused on the issue of the conservation of life by looking at the physical laws. And a lot of what you're going to hear this afternoon is that our biology is really controlled by a set of physical laws. And when healthcare financing and policy does not align with those physical laws, you increase the likelihood of poor outcomes for patients. And so this 15-blog series launched on July 6th, and the second article in the series is going to be on ESRD and the bundling and its impact on those on dialysis. So if you look at the QR code there and you scan it, it'll take you out to that series, and the first article in the series is there. And finally, we invite your comments. Next slide. And so there's a place where you can go in and comment on it, and there's also a deck that will introduce you more deeply to what we are talking about when we talk about the physical laws framework. So thank you very much. What I'd like to do now is kind of get us started with our panelists. So I'm going to ask Ms. Buckley to begin our comments.
Thank you so much, Dr. Puckrin. I'm pleased to join you here today, and I will be focusing my remarks on laying the groundwork on the ESRD Prospective Payment System, or PPS, also known as the bundle. I'm going to talk very quickly because there's a lot to cover in that regard. And as I'll explain in these slides, bundled payment systems work well for surgeries or procedures to encourage efficient resource choices, but they do not work well for providing patient choices or access to innovative treatment items. Bundles were a hot ticket item a little bit over a decade ago, but other payment systems since that time have recognized that these have flaws when it comes to patient access. And in other prospective payment systems, we have seen changes to allow for access to innovative treatments. With Medicare's broad eligibility for Americans with ESRD on dialysis, the PPS is one of the only largely single payer systems in the United States. And while the ESRD PPS has been in existence for a long time, in 2011, it implemented an expanded system that now includes drugs, laboratory services, other items and services that historically had been billed separately from the dialysis procedure. It includes things like Part B ESRD related drugs, Part D ESRD related drugs, and oral only drugs, which we'll talk about today, made their way into the bundle in 2025. Medicare makes payment for all of these items and services through a bundled or lump sum payment, which is known as the base rate. And the PPS and the way it is set up negatively impacts patient access to new medicines. And as you can see in the graph on the right, innovation in this area has been stagnant. Going to the next slide. The base rate that a facility receives for a dialysis session to pay for all of these items is $273. There are adjustments that you can see underneath that payment rate in these boxes to reach a final payment add-on, such as patient-specific add-ons and facility factors. And I'll talk more about the transitional drug add-on payment, or TDAPA, and the post-TDAPA add-on payment as we go to the next slide. Whoops. Change my slide here. So part of the problem with the ESRD PPS is the way in which the renal dialysis services definition and other related definitions has resulted in an extensive array of items and services being pulled into the bundle. Under the new drug designation process, any drug that is considered to fall within a functional category flows through the pathway that you can see on the left-hand side of this slide, where there's a short-term add-on payment, the TDAPA, and no long-term base rate increase. A functional category is a technical term, but it basically means a distinct grouping of drugs or biologics that have an end action effect to treat or manage a condition associated with ESRD. So for example, bone and mineral metabolism or anemia management. The problem is that the functional categories are so broad that it is difficult for new drugs to be categorized as not falling within a functional category and leading to a base rate increase. CMS has broad authority over what is deemed a renal dialysis service, as well as how it moves through this drug designation process. And the add-ons are time limited and inadequate. The calcimimetics and the phosphate binders fall into a functional category, but went through a very special process for the years that they have come into the bundle. And I'd be glad to talk about that during the panel. On the next slide, I'd like to contrast this to a different payment system. As I mentioned in the opening, in other PPS systems, CMS has recognized the access challenges that payment bundles do pose. So on the left-hand side with the ESRD PPS, access is constrained and innovation has been stifled. So for example, the ESRD PPS now pays for prescription drugs that are taken at home by patients. That would never happen under the Medicare OPPS, which reimburses hospitals for visits of patients to the hospital. Drugs that are taken at home by a patient would stay in Part D. They would never become part of the payment for a service provided at the hospital just because of the patient's diagnosis. Under the PPS, for drugs that fall within a functional category, as I showed on the previous slide, there's a 2-year add-on at ASP plus 0%, versus in the hospital outpatient department is 3 years and generally at ASP plus 6%. After the TDAPA period ends for a drug in a functional category, there is a post-TDAPA add-on payment for 3 years, but it doesn't follow the patient. It's added pennies to the dollar to each claim, but is not enough to reimburse for an actual month of drugs provided to an individual patient. Versus in the hospital outpatient department, there's long-term payment after pass-through status for most separately payable drugs at ASP plus 6%. In the ESRD PPS, after the post-TDAPA add-on payment 3-year period ends, there's no base rate increase after that add-on payment concludes, and there are no pathways for seeking access to these products or for special payment processes. Versus in the OPPS, even outside of separately payable drugs, there are pathways for like a cell and gene therapy carve-out list to make sure they're paid separate from a procedure. There are new tech APC payments, and most recently, separate payment for diagnostic radiopharmaceuticals. So moving to the next slide, in summary, the reach of the ESRD PPS has expanded far beyond payment for a dialysis session, and this expansiveness is harming patient access to treatment choices. Advocacy is underway to exclude innovative phosphate-lowering therapies from the bundle, both before Congress and before CMS, as well as efforts to press for broader reforms. And I look forward to discussing these issues further during the panel.
So I had myself on mute. Next in the panel, I'd like to introduce Dr. Tumalala Pali. Dr. Pali, if you please.
Great, thank you. It's wonderful to be here. So in these next set of slides, we're going to examine how the ESRD bundled payment system has affected the use of various medications. So here we can see on the graph, this is data from 2011 when the bundle, the ESRD PPS, was first implemented. So in the gray, we have EPO or erythropoietin use, which is a medication for anemia. And in the yellow, we have hemoglobin levels. So we can see before the bundle, we have rising doses of EPO over time. And this was before the bundled payment was in place when it was paid fee for service. And after the bundled payment, if you click through, we can see a sharp and marked decline very quickly in EPO use, and hemoglobin levels also declined because facilities are no longer incentivized to prescribe the EPO, and it's under this bundled payment regardless of the dosages used. And on the next slide, we can see how types of iron on dialysis changed after the ESRD PPS bundled payments. So dialysis organizations, they shifted away from more expensive formulations toward cheaper alternatives. So much of this was through formulary changes, formulary restrictions. So we can see that dialysis facilities, they were able to respond very quickly to incentives for a couple of reasons. So the dialysis industry is very consolidated. 90% of facilities are in chains. 77% of facilities are in the 2 large dialysis organizations, and 90% of facilities are for profit. So on the next slide, moving to more recent data, we can look at calcimimetic utilization during TDAPA and after it was incorporated in the bundle. So there's 2 types of calcimimetics, cinacalcet, which is a once-a-day pill, and etacalcetide, which is an IV medication administered on dialysis. So during the TDAPA add-on payment period, etacalcetide use peaked at 10.4% of patients receiving it. But in 2021, when it was incorporated into the bundle, $10 was added to the base rate, and we can see an immediate and rapid decline to only 3% of patients receiving it, down from over 10%. The total calcimimetic use stayed constant, so there was a 1-to-1 substitution back to cinacalcet, and cinacalcet also went generic during this time, so it was much cheaper than etacalcetide. And on the next slide, we can see this really had clinical consequences. So patients who discontinued etacalcetide, even though most of them switched to cinacalcet, they had worse mineral bone disease control as measured by these PTH hormone levels. So here we can see the PTH levels stratified by race, and higher levels are worse. And we can see the increase was highest and worst for Black patients, which may be due to a variety of factors such as differences in dietary patterns or vitamin D levels. So in the next slide, this brings us to 2025, where now phosphate binders are being included within the bundled payment. But there's a number of different logistical differences between phosphate binders and calcimimetics. So phosphate binders, they're all oral, they're not administered during dialysis. Sometimes we can give the cinacalcet pills or the calcitriol pills at the dialysis session. But phosphate binders, they can be up to 9 pills a day. They have to be taken with meals. So dialysis facilities, they have to dispense this large volume of these medications. And instead of just 2 options like the calcimimetics, there's many different types of phosphate binders to choose from. So there's a lot of logistical complexity. So this policy change, if we click once more, it really has massive implications for patients. It affects 64% of hemodialysis patients, 56% of peritoneal dialysis patients. Dialysis organizations, they either operate their own pharmacy or they contract with a pharmacy in order to accomplish this. There is a $36 monthly dispensing fee in addition to this temporary TDAPA add-on payment. And the phosphate binders, they're delivered to a patient's home or they're distributed at the dialysis facility. So a lot of logistical challenges here. And this has huge implications on our healthcare system, given that nearly $1 billion is spent on phosphate binders annually. So I look forward to our discussion today.
Thank you so much, Dr. Tumalalapalli. Next, I'm going to ask Dr. Jeffrey Paramuta, please.
Thank you, Dr. Puckrein. I do not have any slides. I'm the one here who was asked to join you to kind of give you a practical perspective as a nephrologist practicing in the community as a dialysis unit medical director. And also have quite a long-term experience pre-bundle and post-bundle. And I agree with the prior 2 speakers, excuse me. And so if we go back in 2011 with respect to the bundle, what that affected mainly were injectable medications. There really were very few oral equivalents except in people who were on home dialysis. And so Dr. Tumalalapalli mentioned a medicine called calcitriol, which is an activated vitamin D product. Home dialysis patients could not get what was then being used in hemodialysis or in center patients, which was injectable vitamin D. And so provisions had to be made to provide those patients with oral calcitriol. And at that time, even the largest of the dialysis companies contracted for that service because there was not enough volume to justify having their own pharmacies. That may not be true across the board, but was mainly true. I would like to comment with respect to the change in the use of recombinant human erythropoietin. You have to remember that at the time that the bundle came in was coincident with fairly large studies looking at uses of erythropoiesis stimulating agents at that time, mainly Epogen in dialysis. And in fact, those studies indicated that there was harm in increasing hemoglobins above a certain level, and there was no harm in allowing them to fall about as far as 9. And that was coincident to, and prior to the bundle coming in, I was reducing my use of ESA for safety reasons, and knowing that there was unlikely to be any adverse outcomes which had been demonstrated in the studies, albeit those had not been in dialysis patients, but that was the best data available. So that was sort of coincident. And at the time, there was also guidance from the FDA about treating to higher levels of hemoglobin. So part of that worked out fairly well. The unfortunate part is that the safety measures that we use in dialysis to protect patients are somewhat obscure. And for anemia treatment, it's the standardized transfusion rate, which is not something that one can know on an ongoing basis and is not helpful in the ongoing care of the patients. As we move along in time, the next change one sees with the bundled medications are again going to the calcimimetics, which initially was just the oral cinacalcet, and then the intravenous equivalent or similar medication, the etilcalcetide. And in that case, then the dialysis units again had to supply more medication to the patients, although again, not in large quantities, since those are medications generally taken 1 pill a day, sometimes 2 pills a day. And those had to be supplied by patients. And so the dialysis companies tended then to use their own mail order pharmacies to be able to get these medications to the patients. And one has to remember that a lot of the point of the bundle is to avoid cost shifting, which clearly is not what has happened, especially when you look at the calcimimetics. But the idea would be that if there was an oral equivalent to an IV formulation, so let's say vitamin D is a good example of that, the dialysis units wouldn't have been incentivized to shift to an oral vitamin D covered by Medicare Part D, and removing the cost from the intravenous form. So they were both included. The problem with that is that when both are included, then there tends to be a shift back to the oral, especially when the oral goes generic, as did cinacalcet. The phosphorus binders were intended to be included in the bundle back in 2011. For a variety of reasons, including lack of cost data, they were not included. They were delayed again in about 2020 and have now been included. The problem I see with including the phosphorus binders is that there's no cost shift within dialysis. The dialysis units don't shift any cost onto the Medicare D formulary with the use of the phosphorus binders. And so it doesn't, not to me, make a whole lot of sense as to why that shift was made. And what has happened now is all those medications have to be mailed to the patient from the mail order pharmacies. The larger dialysis companies have their own mail order pharmacies. Smaller dialysis units have to make arrangements with mail order pharmacies, and they can do that through certain organizations. And then we end up with more novel medications, one of which is used for control of phosphorus. And then the company that's making such a medication has to decide, are they going to go into an add-on payment where there may be use up front and then it's going to drop off, or they are going to stay outside. And to finish up, I mean, if one looks at the amount of innovation in dialysis, exactly maybe there might be 6 or 7 medications that have been developed for use in dialysis since the bundle. If you look at the care of chronic kidney disease patients, where of course they're outside the bundle, there is now a plethora of new medications to help forestall the development of the need for dialysis, delay the progression. And these are quite numerous and more generating all the time. There's a great deal of innovation now in the treatment of people with kidney disease, much of which we did not see through most of my practice lifetime. And there's been very little innovation in the dialysis space. My only caveat would be, and this goes to broader issues, if one actually looks back at the introduction of erythropoietin into dialysis, which was in 1989, and then looks forward at pharma development from 1989 to the bundle, that wasn't such a terrific period either. There's some modifications in intravenous vitamin D, some refinements in the iron products, but actually not much else happened either. And so dialysis presents us with a very, very difficult situation with respect to innovation that I think actually goes to the base of how dialysis is paid even before the bundle. And I'll finish there. Thank you.
Thank you so much, Dr. Paramuta. Finally, I'd like to ask Dr. Underwood, please.
Sure. Thank you very much, Dr. Puckrin, and certainly a pleasure to be here with you today. And I certainly thank National Forum for having me involved as well. Just as you had stated earlier about the collaboration between the Association of Black Cardiologists and the National Minority Quality Forum to specifically look at those individuals who have this combination of cardiovascular disease, metabolic disease, and renal disease, is basically what has set me here today. I feel like a little out of like a fish out of water because I'm with a lot of nephrologists and I'm a cardiologist. But we do understand that almost 80% of dialysis patients actually have cardiovascular disease as well. And certainly cardiovascular mortality is much more common in people with dialysis, perhaps 10 to 20 times more common than in just the general population. So this set of patients is very important to us. The Association of Black Cardiologists looks at barriers to care for people to achieve optimal cardiovascular health. And so basically overcoming disparities and understanding where these disparities and difficulties and barriers to care may actually occur. And it seems that certainly with some of the phosphate binding medicines, which bind phosphate and can lead to vascular calcification, which is really the harbinger of dialysis patients in terms of the cardiologist, where the blood vessels are calcified, the valves are calcified. A lot of the morbidity comes from the calcification. So any agent that can reduce some of the cardiovascular stresses imposed on chronic dialysis patients is extremely important. And so understanding, certainly from a cardiology standpoint, that a lot of the issues are multifactorial. Again, we just mentioned, cardiovascular disease, metabolic disease, renal disease. Patients are on a lot of medications, and a lot of them have been shown to have a mortality benefit, significant reduction in mortality. And it's important for us to make sure that our patients are able to access those medicines, which may help them live longer. So I'm very interested in understanding more, and certainly giving the perspective of those vulnerable patients whose lifeline is very tied to their management of their renal disease, and what we can do to assure that they have the least impact to their cardiovascular health. Thank you.
Thank you so much, Dr. Underwood. I'd like to open up our conversation, and I'm going to ask the other panelists to put their videos on, if you don't mind. In Washington, when it comes to healthcare, we talk so much about financial risk mitigation, and we lose sight of the fact that really the business of healthcare is about conserving high quality, long lives. And we have such a distinguished group of nephrologists here. I'd just like to start off with really a simple set of questions, which is, talk to us a little bit about what the kidney is actually doing in terms of filtering and management of minerals for the body. I think that's an important place just to level set that basically what is the kidney doing, and what is it that we want it to do when the patients are on dialysis? So I open it up to our nephrologist. I know it sounds like an easy ball for you to swing at, but I think it's so fundamental to the question of the day. So I'd like to start off just there, if you don't mind.
I can start. So yeah, when the kidneys are not functional, you have less filtering of phosphate from the blood. The phosphate building up and other hormones like FGF23 have this adverse cardiovascular effect. So you get vascular calcification peripherally in the cardiovascular system. And then uremic toxins as well have a systemic effect. So they have bone marrow suppressive effects, systemic inflammation, immune dysfunction, but they also lead to accelerated atherosclerosis. And then when patients are on the dialysis circuit itself, that is a source of a kind of external inflammation, which also leads to accelerated atherosclerosis. So, these patients, they really do have a high burden of cardiovascular events, as well as, bradycardia, sudden death. I think a lot more can be done scientifically to help these patients improve their cardiovascular outcomes. Most of the time, our dialysis patients, they're excluded from trials So there's really a lot we don't know about the optimal management of these patients. Their atrial fibrillation, what is the evidence behind the DOACs? So, I think there's much more we can be done that can be done to improve their cardiovascular outcomes.
Yeah, I'll add to that since we brought up the issue of parathyroid hormones. So as the kidney's filtering capacity decreases, the retention of phosphorus actually triggers elevation in parathyroid hormone, which initially is relatively modest and does not often require treatment in people who are not yet on dialysis. But as kidney function continues to decline, as people reach end stage, and actually are on end state, then on dialysis, the parathyroid hormone tends to be very, very significantly elevated. The best way to control that, obviously, is to control the serum. It's not obviously, but is to control the serum phosphorus level, which is the linchpin for this entire system. It's also the most difficult thing to do, not just pharmacologically, but from what's required from the patient in terms of limiting their diet. It is next to impossible to limit phosphorus enough in your diet to be able to control that without using a phosphate binding medication. As the parathyroid hormone level increases, we often use activated vitamin D, and then as they became available, we use calcium mimetics. But what elevated parathyroid does then is to increase bone turnover. And so one of the problems with phosphate management in dialysis patients is that the bone is a pretty significant reservoir of phosphorus, as are soft tissues. And so even though dialysis is not, it can clear phosphorus at a reasonable level for the time that the patients are on it, there's a reservoir of phosphorus. And so the phosphorus levels go back up, parathyroid levels goes back up, and it becomes a very, very difficult cycle in which to interrupt the care. I would also comment, since Dr. Tumapali got a little bit more general, the volume removal on dialysis that we do also is deleterious to patients. It's actually probably bad for their kidneys. It's also bad for their hearts and their brains. The cardiologist will be familiar with cardiac stunning, which may occur during dialysis, and there may be some brain stunning as well. And one of the reasons, for example, that home peritoneal dialysis and home dialysis actually helps retain residual kidney function is because of the lack of this rapid removal of fluid, resulting in hypotension during dialysis. And so you've got all these factors coming into play where it makes it very, very difficult. The best way to treat cardiovascular disease in dialysis is kidney transplant or extremely high volume home hemodialysis. And home hemodialysis itself, perhaps we'll talk a little bit later about technological innovations, but home hemodialysis itself can result in a better control of phosphorus because there's more frequent dialysis treatments.
So it's fair to say that there are biological imperatives that are going on in order to sustain patients who are on dialysis, and it's complex. Managing the minerals is one of the things that's incredibly important. And public policy doesn't change that. That's going to happen. And so I think that's really important for everybody to bear in mind. I know physicians understand that, but I'm not so certain that all the time our public policy people understand that there really is a system going on that requires intervention and attention. And that's what dialysis is trying to accomplish, and that's what these medications are doing as well. So then I ask you, and I was looking at Lauren's slides that she was showing, and hopefully they can pull up that one slide that shows TDAPA and cost of this and that, because there isn't anything clinical there. If I'm asking now the nephrologist, is there one thing clinical in that set of whatever that CMS has concocted to regulate getting medicines to people in a timely and efficient way? And I think Dr. Tumapali was showing that there was some breakdown in terms of when these medications get into this payment system, in terms of getting to the patient in a timely way. Have I misstated the problem in some way? I'm now asking the nephrologist, and then I'd ask Lauren if she would jump in as well.
That was a great statement of it. Yeah, from 2020 to 2021, when etacalcetide entered the bundle, there was nothing biologically different about the patients. I mean, COVID was going on and everything, but it's purely a payment change as a result of the policy decisions.
Lauren, can you talk a little bit about, now we're going to go to this financial management side of the house, which people talk about as a branch of medicine. I'm not exactly sure that that's what's going on here, but can you talk a little bit about what's the intent and purpose of these payment models?
Sure. So, I think that Dr. Perlmutter was talking about it a little bit during his remarks, that the idea with the ESRD PPS was to try to find a way to not have cost shifting, and how to try to have a contained payment system related to the dialysis procedure and then things like EPO. That's what was really a big focus, I think, at the time that it had started. And the way that the functional categories have been set up for determining whether a drug gets a base rate or not was really set up, I think, initially to provide clear guidance that anything that can be considered ESRD related is part of the functional categories, because there are instances where a dialysis facility may treat a patient for something while they're there that is not ESRD related, and they can bill for that, and they can bill for that outside of the bundle. So they need to have some guidance related to that. But the idea with the PPS was for it to be one system where CMS, through prospectively set rates, knows what it's going to pay on the outset. Because one thing some of us tend to forget is that most Americans make their way into Medicare for ESRD treatment. And it's really one of the only diagnoses where everyone in the country ends up in the same payer system. And that's really where we're seeing the problems that are happening as time moves forward. It's very hard with payment bundles to provide access to treatments that are, there's a question in the chat there. It's hard to provide treatments that are based on the patient's profile. You really have to look at the financials for the bundle and what can fit under that bundle payment. And that's how the choices are made. There are financial choices that have to be made when that's the reimbursement that's available. And so there was a remark made about how moving the phosphate lowering therapies didn't make a lot of sense because there wasn't a cost shift happening. There were not IV therapies that were being provided where bringing them in would help avoid this cost shift. They were already in Part D, where there was negotiation happening with the plans. There was, kind of a tiering of systems, but if a patient needed something, there's a way to appeal and try to get that.
So if I'm understanding you correctly, and correct me if I'm misstating it, there is nothing clinical in the payment model that is looking at whether in fact the payment model itself is bringing, I'm going to call it disorder if you don't mind, but it is not helping regulate the management of minerals in the patient. I mean, there's no measurement. There was no discussion about, is this going to improve patient outcomes? It was really a financial conversation. Am I missing that point?
Right. No, you're exactly correct. There was supposed to be a quality measure that was going to be included at the time that the phosphate lowering agents came into the bundle. This was actually something that the government talked about, looked at. There was a lot of hand wringing over the fact that there was not a quality measure. And it's almost like it's been forgotten. CMS doesn't talk about it. It's not discussed in the rule. There's no discussion in this year's proposed rule about access challenges, outcomes, all of these things that they had said were important for why this should happen. And so there really isn't a way through quality measures that this is being tracked.
So I'm going to
I'd like to
transfer. Please,
I'd
go
like
ahead.
to comment that those of us who take care of those patients have not forgotten what matters, and we still work as hard as we can to uh, try to get control of these situations. It is true there's no phosphorus level quality program. There's a measurement requirement that you measure phosphorus levels, but there's no quality measure that relates to phosphorus control. There's one that relates to hypercalcemia that's sort of topped out and has very little to do with the actual patient care. And there's nothing clinical in the bundle. That is an absolutely correct statement. And that's unfortunate.
So I'll say it back, and I'm saying this in sympathy to the nephrologists who have to manage in the context of this financial framework that is established, that is non-clinical, but yet has clinical implications for the patients, if I'm saying that correctly. So Dr. Underwood, you're downstream from this, so you catch exactly the end result of the way in which the financial management system is operating. And the point I'm making is it's tending to elevate cardiovascular risk. Is that a fair assessment of what's going on?
Right. So I think it's not necessarily elevating it because it may be consistent with the status quo, but it's certainly not doing anything to lower it. And so what we're concerned with is our strategies that can lower cardiovascular risk. And as you've just discussed, or we've discussed, there's nothing clinical in this strategy at all that's doing anything to improve the patient, their outcome, their ultimate outcome. And this is some difficulty with them being able to access the medications that could help them to live healthier. And so that is the concern when it comes to our desk, say as a cardiologist. Also, again, the adherence. Certainly cost is very important, but the patient's ability to adhere to the regimen and then to receive results. And I certainly appreciate the comment about no quality measures, because it's very important that these therapies are monitored to assure that the patients are having the outcomes that we anticipate. And if there's no measure, and certainly in the current environment, there is less emphasis on any type of regulation and quality, I think it does leave this population of patients very, very vulnerable to be impacted adversely by some of these shifts in what medicines they have available to them.
Dr. Paramita, in your opening remarks, you talked a little bit about the impact of innovation, particularly for patients who are requiring renal replacement, as it relates to, in effect, the government stepping in to pay for dialysis care. Can you talk a little bit more about the state of innovation? Upstream, you're saying we're getting smarter and smarter about how to manage kidney disease and keeping people off of dialysis. But talk a little bit about the world of patients on dialysis and what innovation looks like for them.
Right. Unfortunately, innovation does not look like much. I mean, I went through the CMS website and counted off the number of pharmacologic products that had been introduced since either around or since the bundle, and they are 7 total, and most of them would have to fit under the bundle. There's a couple of anemia drugs that are oral that would have to go in the bundle because there would be a cost shift then. There are other medications that would replace those used during dialysis. And when they first put together the bundle, they took all their, as described by CMS, they took all their claims data, and they came up with quite a wide range of medications that you would not expect to have seen, including narcotic analgesics for which there was claims data. And we had some hiccups early on with pain medications and also with antibiotics, which are also covered under the bundle for treatment of dialysis access infections, but are not covered for other infections, and it got to be a little bit of a problem. So very, very little innovation, in the dialysis space were really, except for the one kind of unique product that has recently been introduced for control of phosphorus, there haven't been any new phosphorus binders for several years. And part of that is it's a relatively small market for a medication, several 100,000 people versus big cardiac drugs, which will be millions and millions of people. And part of it is because of the payment issues in that, knowing that the return on investment will be smaller. If you look at innovation in terms of non-pharma, and Ms. Buckley didn't mention this, but there's also an add-on payment for new and innovative equipment and supplies. There's very little innovation there too. There were two things that were approved, and it's called TIPNIs instead of TDAPA. There were two products that have been approved under TIPNIs. One a dialysis machine, another a dialyzer, the filter that we use for dialysis. And there can be cardiovascular implications of this. As I alluded to, home hemodialysis might be very effective for more patients that are getting it. It's not easy to do. It's not made easy to do. And then there are some upcoming introductions in terms of what's called hemodiafiltration, which is using both diffusion non-dialysis and then actually convection. Dr. Underwood, if you're used to taking care of patients in the hospital who might be on continuous renal replacement therapy, there's replacement fluid that is given to allow for a higher level of clearance. And actually, you can do this on dialysis as well, but you have to have a special machine. It's going to be much more costly, and it may have cardiovascular benefits, not just within mineral metabolism, but in other ways. But that's going to come out very slowly, and it's going to really require the payer, as you might refer to it, to be willing to pay some money up front to allow this to happen, so that we can see the benefit for patients downstream. There's really a lack of risk taking on, if you want to talk about on CMS's side, in terms of being willing to spend some money and to prevent bad outcomes, including hospitalizations, which are very, very costly.
Dr. Tamapali, talk a little bit about sort of bundling and innovation and the impact that it has or does not have on stimulating innovation, again, in that space where patients are on dialysis.
Yeah, I think Dr. Perlmutter's comments are very well taken. We've seen a couple recent examples that shows how, the current system is inadequate. So there was a medication called difelikefalin, Korsuva, difficult to pronounce, but it's used for pruritus, which can be, very debilitating for patients, the itching with all of the toxins building up. And so there was an add-on period. And one of the problems with the current system is you only give the nephrologists a couple of years to adopt this new therapy before you decide how much money to add to the bundle when it's incorporated into the bundle. And so in that case, just some cents were added to each claim. And so rather than saying, we're going to give this medication to some patients and then take it away later because the payment is inadequate, I think that medication was never really fully utilized to its potential. And so many more patients could benefit from that therapy, but never got access to it. The TIPNIs, the new drugs and the new devices payment, the issue with that is there's this substantial clinical improvement criteria. And so not all devices actually qualify for the add-on payment. There's an application process. And so one that was related to, it was the Buzzy Pro device, this access device that reduced when you cannulate the access in order to hook the patient up to dialysis, it reduces pain. That was rejected. And so there's kind of lack of clarity about whether your new device would actually qualify for the add-on payment. And so that uncertainty is a disincentive to innovation in this space as well.
There's a question in the chat that is sort of the question that you often get in Washington, which is, how does one incentivize innovation while at the same time incentivizing cost effectiveness? And I won't prejudice any responses that anyone might have, but certainly I put that out there because it is the common question in Washington. If you innovate, you've got to simultaneously reduce costs or show cost effectiveness, or anyway, I'll leave the answer to you.
So I'll take the first stab because this came from one of my fellow board members. And Ted Shakowitz, next time I see you, we will be having a discussion about this. I'll get you for this. But I mean, that's extremely difficult. And I'd be honest with you, it says, would flattening the profitability of different types of treatment help? I would ask for a little clarification on that. I think part of the problem, and Dr. Tumapali alluded to this, is that the lead-on time to get comfortable with the therapy and to fully adopt it is just too short. By the time the drug, the product enters TDAPA, I mean, then it's got to get out there. That's 6 months of just getting product out there. So you've lost half a year, and then till you pick it up and you figure out, then you got to survey who's itching and get the product, and you've lost half the time. And then the amount that is then added to the payment for the product is much smaller than if you kind of continue to see the product grow. I will leave it to Dr. Tamalapalli to try to answer the question of cost effectiveness. I mean, one thing to do is, which we were seeing in the kidney community, is in terms of taking risk for providing care. And so I alluded to hemodiafiltration. If you're in sort of a value-based care model, and I'm not going to say that those value-based care models have been shown to work, but if you have a model where you're going to spend to save, unlike Medicare, which has Part A, which is where the savings would be from the spending in B, if those are integrated either through a value-based care model, or now we're seeing, don't forget, we now have to contend with Medicare Advantage, and just as 50% of patients on Medicare are now in Medicare Advantage, so too are dialysis patients allowed to, and there are many are moving towards Medicare Advantage so they can avoid having to pay the premiums for a Medigap policy. And now you have another set of payers with which to deal with and to try to get these things through. But if you're in that model where the savings go to the same entity that did the payment, then you might get somewhere. Again, I'm not promising that those models have actually been shown yet to work. But again, full disclosure, I'm in a kidney care entity in a value-based model, and the payments to physicians have just been decreased. Now, it was just payments to physicians. They felt they overpaid us. Okay, so fine. But that was just after a year. There's no accumulated time to see how things evolve and to see where we go. Maybe the next 2 years we save so much that it was worth paying us that money up front. We won't know. Taking it away before they know what's actually going to what has happened with the model.
Lauren, I'm going to ask you to step outside of the ESRD bundling system to talk about your thoughts on what would be the payment model if you were given the pen and said, yes, we need a payment model to manage these patients. What would you do? How would you think about that?
I would think about that in terms of the dialysis procedure and what is most important to the dialysis procedure and the types of items and services that are integral and ancillary to performing dialysis, and think about how access can move forward. So perhaps where the phosphorus lowering therapies had been in Part D, where there was negotiation and access and choices for patients, and to try to have it look a little bit more like Medicare looks for patients with other diagnoses. If you think about it, when you have an ESRD diagnosis, you then are are in the bundle, and you have the treatments that are available through the bundle based on the way the finances operate. But if you had a different diagnosis, you could have a procedure performed in the hospital outpatient department and go to see your doctor separately and have drugs prescribed that you can get either, in the doctor's office, or you could get them through your Part D plan. I think it would be much more feasible for it to operate in the way that other parts of Medicare operate.
I would like to,
Yeah,
I'd like
please.
to comment. The
Yeah,
problem is that their allowance was made in 1972 to allow anyone with ESRD to be covered under Social Security Medicare, and therefore we have many, many, many more patients in the program than there would be otherwise, for good cause. I mean, people could not get dialysis. People were dying without dialysis. Committees were deciding who got dialysis, and this allowed a life-saving therapy to be promulgated to many more people. But it's gotten to the point, I mean, everybody knows these statistics, 7% of the Medicare spend is for 1% of the patients, and those are my patients on dialysis. And so I just think we're beyond that point where you can separate that out. And I actually think I would go big. I'm not sure that how the model can be created. I'd actually go big, where the entire spectrum of care is actually got to be incorporated. For too long, we've separated out, for example, transplant from the rest of kidney care. They're on their own little island. They have now their own payment plan called IOTA, improving transplant access. But that doesn't help in the transition of payments from me to them, and then oftentimes from them back to me, back to Dr. Tumapali. And so in some ways, I think one would need to go big rather than limited in terms of doing that. No promises that would actually work, but that's how I think about it.
When you're almost at time, and I'm going to ask each of you to think of a closing remark, I'm going to set it up to say it this way. I come from the patient advocacy perspective, and in that world, conserving life is the highest priority, and financial risk mitigation is secondary. If you have a healthcare system that has put the primary emphasis on financial risk mitigation, I would say that's not healthcare. That is doing something other than healthcare, particularly when, as we've already seen with this system, you're not even measuring outcomes. You're not even paying attention to what's actually happening to the patients on dialysis as you potentially elevate risk for them by the way the payment models are set up. So just a fundamental rethinking and reordering of what it is we're trying to do, at least from the patient advocacy perspective, would be it. But anyway, having that said, I'm going to start with Dr. Underwood and ask for your closing remarks, and then Dr. Paramita and Dr. Tamapali, and leaving the last to Ms. Buckley.
Sure. No, thank you. Thank you very much, Dr. Puckrein. And I certainly echo your concerns from a patient advocate standpoint. And when we have, as been described, reduced reimbursement, so the bundling is less, so there's less profit in taking care of these patients. Now you've also added medications, which there could be profitability seen by the system, by the prescriber in that sense. And so that's the person making the decision on what's going to take place on that patient. So the money's running out, and I have an opportunity to save money, but there are no quality measures that dictate how you actually use those medications. I can imagine that it will come back to, more than likely, people not having access to the more advanced therapies. And this is something I've seen certainly in other stressed healthcare systems, like Indian health system, where you'll have very old medications being used on patients in a contemporary time, which really don't need to be used anymore. And the outcomes reflect that, just as I said, the 10 to 20 times more mortality is inherent a lot with how the patients are managed long term. So I think that having quality measures associated with some of these financial risk mitigation aspects would be very important and certainly should not be neglected.
Right. Dr. Paramita?
I agree with Dr. Puckrein. I would say that in the kidney care models in which we operate, outcomes are important and quality is extremely important. The problem is that it's much easier to affect on the pre-dialysis side. And I'd always say that Dr. Underwood, Dr. Tumapali, and I, we're both upstream and downstream. Cardiac diseases upstream as well. I would just close by saying that we've got some interesting points of view coming from different perspectives here. And I think it's going to be important for us to go together to the payer or to the payers, and rather than going separately. And certainly the RPA is interested in working. We've worked with other organizations, but we've got to kind of get us all together to improve the care for our patients.
Dr. Palmer-Molly?
Yeah, I agree that quality safeguards are extremely important. There is a robust ESRD quality incentive program. There's 15 quality measures, but I think designing it thoughtfully in a way that is not overtly burdensome to dialysis facilities, while at the same time measuring kind of what matters the most is really critical.
And Ms. Buckley, we leave it to you.
So I'm an access-oriented person, so I would have to say, I really think thinking about what innovative pathways look like, how those can be used, and how they can be used in not a stopgap way, but in a long-term way to provide patient access. Also, I agree, all stakeholders really need to work together, come to the table. There are a lot of reform ideas. There are a lot of smart people involved in this world. Are there ways to get additional funding from Congress? There are a lot of things to be thought about, I think, moving forward for the future. But I think that for right now, trying to put the patients at the center of the reform and having these better access pathways would be the best way to start.
Thank you. Thank you to the panelists, and I'm going to turn it back to Jean.
Thank you so much, panelists and everybody, for joining us today. We have what the closing poll to bring up in terms of gauging what you learned today and your level of importance on this topic. So we ask that you just take this poll one more time in terms of your understanding of today's topic.
All right. Votes are flying in. We'll give it another 5 or 10 seconds.
Excellent. Thank you so much, everybody, for participating in today's poll. We're pleased that your understanding levels have increased, and we will provide the recording for today's session as well as related resources on the National Forum's website and email those out to you. We also ask that you take a moment to complete a brief survey regarding today's session, and if you have additional topics that you would like to cover in the future, please let us know. We welcome your feedback. On behalf of the National Forum's Value and Access Collaborative, I want to extend our sincere gratitude to Ardelyx, the BMS Pfizer Alliance, Novartis, and Regeneron for their support in making this briefing possible. And of course, a special thank you to our incredible panelists and moderator for sharing their expertise and perspectives today. Thank you, and we look forward to continuing this important work together. Have a great day.